Welcome to Grand Rounds. It's my pleasure this morning to open our auditorium again. We don't have a lot of people here yet, but I want to let you all know out there in the universe that we are at half full, which means we can put 90 people in our auditorium now, and we welcome you back. We haven't got any treats for you or anything yet because that hasn't been opened, but we can do this somewhat in person. We're still, though, also and always going to be virtual as well, and so you can send in questions, if you will, to the either on Zoom or media site, and we will ask those at the end. Remember that there's a little bit of a delay, maybe 45 to 60 seconds, and so when Dr. Dandamundi finishes talking, try and send your questions in during the talk so that we'll have them immediately, but if not, we can get them at the end. It is my pleasure this morning to introduce Dr. Gopi Dandamundi. This is a historic moment because I think it's the first time that I've been trying to get someone from the Franciscan side of Virginia Mason Franciscan Health to do Grand Rounds, and I got Dr. Dandamundi's name from a colleague down at CHI Franciscan several months ago, but then we've been talking a little bit about education, and his enthusiasm is infectious, and I said, would you give Grand Rounds? And I don't think I got the rounds part out before he said yes, which I always like to see in this situation. He trained at Ross University for medical school, and then went to Indiana University for his fellowships and residencies, all the way through cardiac electrophysiology. He ended up also at some point getting an MBA. He's a world expert in this field, and he's going to talk to us today, I believe, somewhat about his bundle pacing. Now, I've been taught a lot through the years at cardiology here at Virginia Mason, and I know an elephant's heart rate is 30 beats, but I haven't learned a lot about his bundle pacing, so I'm excited about that today. I've looked in preparing for this, I've looked at a few presentations that he's done, and it's fascinating to me. So I'd like you to welcome Dr. Dandamundi and our partners from Franciscan Health, not partners, but our colleagues from Franciscan Health, and we look forward to a lot of collaborations in the future. Thanks.
Thank you. Thank you, Bruce. And thank you all. It's nice to be back at least somewhat this hybrid mode. Probably have to get used to this. You're used to presenting where people are there and interacting, but I guess it's a new reality for all of us. Interesting thing about this, I don't have time. I was just telling him that potentially I can do a whole talk on the importance of social media today in healthcare. This hashtag, so for those of you who are not Twitter savvy, some of you may not be still, this hashtag is don't diss the hiss hashtag. I created this about in 2015. And it is actually one of the most popular hashtags on Twitter in the cardiology realm globally. And we actually recently published a manuscript on this, the importance of this hashtag in moving the entire field of cardiac pacing globally. So there's a nice story of that by in itself that we can talk about for an entire hour and the influence of that. For those of you, again, you can actually follow a lot of this stuff. Worldwide people do these cases and post them on this hashtag, so it's a repository of education on His bundle pacing and conduction system pacing. My disclosures. It's always important, I think personally, to look back where the past, what we learned from the past, because that's what really dictates the future and where we're going in this whole field, in general, in healthcare itself and medicine itself. Just to show you, this is back in 1928. It's not too far back. If you look at evolution, this is literally about 100 years ago. We didn't have pacing. The first pacemaker / quote-unquote pacemaker was essentially this little device here. It's a crankshaft, so you had to actually sit at the bedside and continuously crank it to generate an electrical stimulus, and you can see the little probe here that actually had to be stabbed into the heart to actually stimulate it. So you can see this was back in 1928. So people were born at that time. If they had complete heart block, no escape rhythm, they could not survive under most circumstances. And for those of you in the field who know the Zoll pads, this is from Dr. Paul Zoll, who invented the Pad Aspect of Defibrillation. You can see this is one of the earlier renditions of pacing at the bedside, these huge boxes to stimulate, so you had to actually put it on a bunch of wheels to ambulate the patient, but these were all at the bedside or in the hospital. So patients could not leave the hospital if they were in complete heart block and they didn't have an escape rhythm. So again, the chance of survival was essentially none if you were completely dependent on pacing in those days. And really, pacing changed in the 1950s. So this is Earl Bakken, the founder of Medtronic, in his garage, actually started playing around, tinkering with different types of instruments and trying to come up with a transistorized type of pacing system. And you can see here, developed the first one with Walter Lillehei, who was a surgeon cardiac surgeon at University of Minnesota. And they actually made the first portable pacemaker, battery operated, that you could actually wear externally and ambulate and actually survive, at least for periods of time. Again, these were not permanent, but at the very least essentially miniaturized and not or connected to an electrical outlet. The other one, actually, people had to be connected to an electrical outlet. There's some stories about power going out and patients actually dying because of no power supply. Just to show how inventors invent, this is fascinating. If you see Senning and Elmquist around the same time, we're working on an implantable pacemaker, and the shape of that and the size of that was determined by a Kiwi shoe polish can. That's the first semblance of actually an implantable pacemaker that was designed was actually based on that. And it's fascinating when you look at some of these inventions and how inventors come up with ideas. Everyday use of objects is how they actually come up with some of these designs. Moving fast forward to what do we do today in clinical practice? So we talk about different types of pacing techniques. The field is evolving significantly, especially in the last 10 years with conduction system pacing, and we'll talk a little bit more about what is the difference between the two. So RV apical pacing, that's your, since 1950s, 1960s, it's your traditional, time-tested, worldwide, the most common way of pacing. Probably 99.5% of patients worldwide get this type of pacing, which is still works well, vast majority of patients. There are some downfalls to this, and we'll talk a little bit about it. It's not physiological, so you're pacing the RV endocardium, and again, I'll show you some pictures of that. And potentially people can develop cardiomyopathies related to the pacing itself. So people have looked at what if you pace close to the conduction system. Our conduction system, again, runs in the septum. Is that better, potentially, because we may engage the conduction system? It's not something that we use normally. Why not use that? Most of you are familiar with biventricular pacing. Again, this is derived from very large randomized trials that shown not only morbidity but mortality benefits, specifically in certain subsets of populations with cardiomyopathies and left bundle branch blocks. And finally, the new kid on the block, conduction system pacing, and there are different forms of it. Again, we'll talk a little bit about the differences and some of the outcomes related to it based on current trials. This goes back to probably one of the landmark trials that was published back in 2003, essentially looking at if you take patients who get regular pacing and their pacemaker essentially, the higher the degree of pacing, the higher the likelihood they develop heart failure. So you can see here in different modes. In this case, the first bar is if you're paced less than 40% of the time in the ventricle, and the other one is if you're paced greater than 40% of the time. So you can see here the Kaplan-Meier curves of looking at event-free survival. The higher the degree of pacing in the right ventricle, the higher the likelihood of somebody developing heart failure. Again, we'll talk a little bit about it later. Why is that the case, regardless of the mode of pacing? And also, physiologically, it's not natural, and these patients are prone to developing atrial fibrillation as well. The higher the degree of ventricular pacing, the higher the likelihood they can develop atrial fibrillation. So pacing is not benign. Although we accept it as, because there's no other alternative, early on, back in the 50s, 60s, 80s, 90s, until we started having BIV pacing, pacing is not a benign thing. It can cause problems in a decent number of individuals. This is a series that was published from University of Pittsburgh looking at their outcomes of patients with RV pacing-induced cardiomyopathy. So in this particular series, you can see freedom from LV decline. So patients who had regular indications for a pacemaker get a pacemaker and they follow up over time. And you can see about 40% of patients actually had a decline in their ejection fraction after pacing was initiated. And if you look at the degree of pacing, again, this magic number 40% comes from some older trials. it shows, again, the higher the degree of pacing, the higher the likelihood. You can see here it actually mirrors that overall, the higher the likelihood of developing a cardiomyopathy. And they started looking at subsets of patients and saying, is 40% the magic number? And some of the trials more recently, even one of our trials, has shown that anything greater than 20% potentially can increase the risk of a cardiomyopathy. It's no different than PVC-induced cardiomyopathy. We say usually once you have a PVC burden of 15 to 20%, you can develop a cardiomyopathy. AF-induced cardiomyopathy all seem to follow a certain pattern. About 15 to 20% of patients are prone to these kinds of cardiomyopathies related to either arrhythmias, pacing, PVCs, AF, you name it, but they all seem to follow a certain pattern. So what is the difference between right ventricular pacing and, for example, biventricular pacing? These are the traditional forms of pacing that we do today, besides conduction system pacing. So you can see the conduction system from your sinoatrial node, spreads to the atria, goes to the AV node, goes to your His-Purkinje system, and then your His-Purkinje system arborizes into a left conduction system. That's what we call the left bundle, the entire thing. And then there's a right bundle, which supplies the right ventricular tissue, essentially. And your impulses as they travel through the His-Purkinje system spread. It's essentially like, think about a tree root system. The entire ventricles on the endocardial side are completely covered by His-Purkinje system. So the impulse travels very rapidly through the conduction system and activates the ventricles simultaneously, essentially, across the entire ventricular mass. So the way to look at this is your Qrs complex. So your baseline Qrs complex, from the time you're conceived to the time you die, goes from probably 50 milliseconds, that's one tiny small box on the ECG, plus another 10 milliseconds, to 100 milliseconds. So you can imagine how much it's conserved over the 90-year lifespan or 80-year lifespan that we have. Majority of us have normal Qrs complexes. That tells you the activation of the entire ventricle is happening within 50 to 90 milliseconds. So it's highly conserved for a reason, because that's how your heart is synchronous when it contracts, and that's how it's highly efficient when it ejects blood. So when you develop a left bundle branch block, for example, the entire left conduction system is not functioning at that point. So your conduction normally goes to the right ventricle, activates the His-Purkinje system, the right side of it. But now to conduct and activate, remember, you have to activate the tissue so that it actually contracts. That's the only way the heart contracts. That conduction from the left side, or from the right side across the septum, has to go through the muscle to muscle to muscle conduction to activate the entire left ventricle. So when you're looking at that conduction on the left side, now there are areas of depolarization that occur before, and as that's repolarizing, the other areas that are occurring depolarizing, repolarizing, depolarizing. So you can imagine the basal posterolateral aspect of the LV is the last part to be activated through this muscle to muscle to muscle to muscle conduction. So that's what we call dysynchrony of the left ventricle and when you have cardiomyopathy. So the whole object of putting a pacing lead when you do Bi-V pacing is to put a lead on the backside on the posterolateral aspect of the left ventricle and simultaneously stimulate the right ventricular side and the left ventricular side to cause synchrony. So that's the whole rationale behind biventricular pacing. But the problem with that pacing as well is about 2/3 of patients respond. It's specifically meant for really left bundle branch block patients because your posterolateral wall is the last part to be activated. If you look at all other subsets where they don't have a wide baseline QRS, usually we say 150 milliseconds, the benefit is really marginal. And in patients anything below that, especially with narrow Qrs complexes, it's detrimental to do Bi-V pacing in those cases. Again, the rationale, if you think about it, is when we're pacing in Bi-V, we're pacing the right ventricle and we're pacing the left ventricle epicardially. The lead is sitting on the outside of the heart. So that's not the natural way of activating the ventricles. The His-Purkinje system is the natural way of activating it. Similarly, when you look at RV pacing, you're actually putting the lead in the RV apex and stimulating the right ventricular tissue. And since you're stimulating the muscle and not the electrical system, the same thing happens. The conduction now has to spread to the left side, has to go through muscle to muscle to muscle. So RV apical pacing is like having an intrinsic left bundle branch block. So we know that in cardiomyopathy patients with left bundle branch blocks, they don't do well. So if you do RV apical pacing, they don't do well. That's why we have indications to do Bi-V pacing in those patient population. So it's to compare both of them, RV potentially can be bad. Biventricular pacing is the lesser of two evils. So it's not the ideal state, but under the current circumstances, based on technology, that's what we have. So once you start looking at, again, going back to biventricular pacing, if you look at meta-analysis of all the trials that have been done, the only benefit that's been shown from a mortality standpoint is the wider the QRS. Makes sense. The wider the QRS, the longer the activation times getting to the left ventricle side. So that's the surrogate of conduction times. The higher the likelihood that if I put an LV lead on one side and an RV lead on the other side, I can make it more synchronous than leaving them in left bundle branch block. But once you start getting narrower and narrower, especially below 150 milliseconds, there's really not a whole lot of benefit. You can see the odds ratio there basically at unity. And you can see it actually gets worse if in narrow QRS complexes. And if you look at the vast majority of our patients, they all have relatively preserved QRS complexes. Even left bundle branch blocks are not the same. Majority of heart failure patients don't have left bundle branch blocks. The people who have left bundle branch blocks are not necessarily wide left bundle branch blocks. They're less than 150 milliseconds. So still, we're talking about a substantial amount of patient population in heart failure, first degree heart block, and so on and so forth, that don't benefit from CRT. And if you look at hospitalizations, again, similarly, the wider the QRS, the higher the likelihood they respond to biventricular pacing in terms of reduction in heart failure hospitalization. So morbidity reasons as well. So again, going back to this whole concept, when you do a biventricular pacing in this case, you put an RV apical lead and then you go to the coronary sinus and you put a lead on the epicardial surface and you're trying to stimulate. So the reason why we do that is because the conduction system is not working. But again, this is a fallacy. All of us learned it early on. When you have a left bundle branch block, the left bundle doesn't work. Or if you have AV nodal disease, the conduction system doesn't work, and so on. But these are all focal disease for the most part. And I use this example for those of you who have seen the movie Seabiscuit. There's a great line in there. He says, you don't throw a whole life away just because something is broken. And that's exactly what conduction system is. Vast majority of the time, I would say in normal individuals, again, these are not people with rare diseases like infiltrated cardiomyopathies and so on, the conduction system may have a focal problem, but the entire rest of the conduction system was working just fine. And it's a hard concept for people to understand early on until we started doing His bundle pacing and conduction system pacing to prove this. Even when we started doing this and we were publishing this, people were actually criticizing us, saying, oh, that's not safe, that's not. Now it's become one of the most common forms of pacing, at least a handful of centers around the world. So why not use the electrical system? Why do we have to place a lead RV endocardially, LV epicardially? It's artificial. It still is not physiological. Why not stimulate your own electrical system at the site of block and activate it and use your own conduction system? So that's the premise behind conduction system pacing. And there are different forms of it. You can pace at any length of the conduction system. You can pace at just distal to the AV node. You can pace in the common bundle. Sometimes you can pace in the interventricular septum and recruit the left bundle. So there are different areas where you can potentially pace from. This is a nice picture. This is a 500 lead body surface mapping ECG from one of my friends up in England. They've done some work looking at activation patterns. And in this case, you can see intrinsic RV. This is your natural conduction, your narrow QRS. And you can see this is a timing of activation. Essentially, the entire RV is very homogeneous in its activation. The entire LV is very homogenously activated because, again, the His-Purkinje system wraps the entire muscle and activates everything simultaneously. When you do what we call His bundle pacing, these are different terminologies depending on what it's recruiting besides the His-Purkinje system. You can see, again, RV and LV look identical to your intrinsic system because you're activating only the conduction system. And that's the holy grail of pacing. If you can actually mimic it, that's exactly what we want out of pacing. There's another term called non-selective His bundle pacing. It's, I think, beyond this talk, but essentially it's recruiting some local tissue. You can't control exactly what it's stimulating at the site. It stimulates the His-Purkinje system and the muscle there as well. But you can see what happens on the LV side of things. It's exactly homogeneous with your native conduction system. And when you do biventricular pacing, you can see the heterogeneity in activation because, again, you're doing LV epicardial pacing, which is not physiological, but somehow in these really wide QRS complexes, it's better than leaving them with the wide QRS complex when it comes to natural conduction. So I'd like to start out with some examples. This is probably one of my favorite examples. learned a lot from it in terms of understanding pacing-induced cardiomyopathy. This is a 19-year-old kid with a congenital complete heart block at age 6. He had underwent a dual-chamber pacemaker at age 17, was feeling a little bit tired, and they felt that maybe he'll benefit from a pacemaker. So this kid, this was back when I was in Indiana University, was bouncing around for 2 months in emergency room to emergency room. They were diagnosing him with viral syndrome and upper respiratory and so on, and basically was having heart failure, and it wasn't recognized. Finally, he presented. It was in severe heart failure, shock liver, multi-system organ failure, and was urgently transferred to our center for an LVAD, ECMO LVAD / transplant listing, actually. Severely dilated. The kid was totally jaundiced. And interestingly, I had just moved to Indiana University. I had gone back there and I did a grand rounds a month before. So the heart failure team, especially the fellows and all that, immediately said, hey, could this be pacing-induced cardiomyopathy? Because that's usually not the first thing they think. And they said, hey, would this be a perfect candidate for hip bundle pacing? That just shows how doing timely lectures influences behavior. Because I wasn't convinced. This is an extreme form of pacing-induced cardiomyopathy. It's pretty rare you'll ever see somebody in multi-system organ failure because of pacing-induced cardiomyopathy. But nonetheless, it was a reasonable argument. Said, it's worth trying. So for a week, he was diuresed, multiple pressors, and when I took him for the procedure, it was an IV diuresis plus 2 pressors. And you can see this is his baseline QRS when he's being paced. And you can see this is what RV apical pacing looks like, and you can see the QRS. It's ugly. It's about 220 milliseconds, and part of this is he has now a full-blown cardiomyopathy, so the conduction times are going to prolong. And this is a kid who was born with congenital heart block. No AV synchrony. Atrium is doing its own thing, ventricle is doing its own thing. This is 10 minutes into the procedure. So you can see here, there's AV synchronous conduction, his own native sinus node activation, followed by his bundle pacing. So now we're actually, for the first time in his life, he's actually getting AV synchrony, true AV synchrony, because this is his native conduction. So we're pacing his Purkinje system and activating the rest of his conduction system. So this is his native QRS activation by stimulating his Purkinje system. Interestingly, you can appreciate how big the P waves are. So this is massive left atrial, right atrial enlargement. You can see there's a little bit of delay in conduction. That tells you there's intrinsic delay because of cardiomyopathy. And this is 4 days later, you can actually see the P waves are shrinking because he's actually remodeling that fast after implanting conduction system pacing and taking him away from RV apical pacing. So this kid, 7 days later, walks out of the hospital on oral meds. He was in the throes of death, literally. They thought he had to be transplanted. And this is all nothing but a form of pacing-induced cardiomyopathy. And we went back and said, this is crazy. This is insane. Let's go back and look and see what happened pre-implant and post-implant. What was his metabolic profile? What did he do? So you can see these red numbers are the day of his bundle pacing initiation. So that's his BNP. And remember, he was on 2 pressors, IV diuretics. Within 2 days, he comes off all his pressors, and he's off IV diuretics by the 4th day, and he's on oral medications. You can see and appreciate what happens in these kinds of failures where there's platelet sequestration, and you can see he totally normalizes within the next 5 days when he walks out of the hospital. You can see his total bilirubin. His pocket was totally jaundiced when I opened it up to change the device. Direct bilirubin, INR, everything, just totally transformed within a few days. He was all over the newspaper in our area and all that stuff because this is a great rescue. But 2 things. One, it shows you what conduction system pacing can do. And secondly, more importantly, what pacing-induced cardiomyopathy can be. So we tend to take it for granted, it's okay, put an RV lead in and so on. But there are people who have these kinds of exaggerated responses, and it's important to keep track of these patients over time because they can develop over time. So pacing-induced cardiomyopathy can develop at the time within first 6 weeks, 8 weeks. Sometimes it develops several years later, even 5, 10 years later it can develop. This is another interesting case. This was a transplanted patient, 70-year-old who had ischemic cardiomyopathy. He had an LVAD followed by a transplant, and we were following him. So suddenly, over a 6-month course, he deteriorates, and he has heart failure, and he presents with an ejection fraction of 20%. Of course, the first thing you worry about is, does he have accelerated coronary artery disease, or is it a rejection, essentially? He goes through all the workup. They find some mild form of rejection. It's not unclear. It's not clear at the time. So he gets aggressively treated, and then they repeat, and they do a biopsies, again, multiple biopsies showing that there's no more rejection, but he persistently has cardiomyopathy. So he's referred to EP for an ICD consideration. So again, interestingly, start looking back at his ECGs. So 6 months prior to presentation, the donor heart that he has actually has a left bundle branch block for the first time. So there's a form of cardiomyopathy which can happen because of left bundle branch. Just like pacing-induced cardiomyopathy creates a left bundle branch, same thing in this case. So looked at this, things have to make sense. But if you look at the timeline, so left bundle branch induced cardiomyopathy. So talk. Microphone may be off, right? And this is with his bundle pacing. So you can see here's a donor heart with a left bundle branch block. We can actually recruit the left bundle branch block. Again, this is not a concept that most people, until we started doing this, understood that you can actually recruit. This goes back to 1970s. People have shown that when you have left bundle branch block, you can actually pace at the site and actually recruit the left bundle. Same thing with heart block, AV nodal block, and so on. All we're doing is carrying it over 30, 40 years later and proving it clinically in daily clinical practice. So his EF improves to 42%. 4 months later, his EF is 60%. So here's a case of left bundle branch induced cardiomyopathy. What is unique about it is it's a donor heart to develop a left bundle branch. Usually donor hearts, they get a lot of biopsies and they develop right bundle branch blocks, not left bundle branch blocks. So it's a little unusual, but it's the first case in the world of a donor heart developing left bundle branch block mediated cardiomyopathy that was actually reversed with his bundle pacing. So this is data from where I was before. So a colleague of mine and I started doing these since 2010. And again, it's an incredible story of how not just us, but worldwide physicians driving this field, because this is not something that companies are interested in, because we're saying that you don't need to put fancy devices, you don't need to put a biventricular pacemaker, you don't have to put extra leads. You can take a regular pacemaker and pace at a certain site and actually prevent these kinds of cardiomyopathy. So you can imagine the uproar it creates in industry saying, oh, we're not sure that's the right thing to do. But we did all this work. This is, for example, patients that we followed. We did about 400 patients that we followed in each arm. So patients who have indications for a pacemaker with preserved ejection fraction get pacemakers, and we follow them over time. And you can see patients who got conduction system pacing fared a whole lot better, relatively speaking, compared to patients who got RV pacing alone. And when you start looking at heart failure hospitalizations based on the percentage of ventricular pacing, same thing, that trend of anything greater than 20%, you can see a clear separation in the Kaplan-Meier curve suggesting strongly that pacing-induced cardiomyopathy can occur in this population. In general, this is more of elderly population with indications for pacing, but conduction system pacing can at least reduce that incidence of pacing-induced cardiomyopathy. This is another study that we published together with a few other sites. These are patients who came for biventricular pacing, who had indications such as the heart failure, left bundle branch block, and so on, and they had indications or they failed BiV pacing. And you can see here we were pretty successful, but more importantly, in this case, you can see what happens to these patients. Overall, these patients had a wide Qrs complex at baseline with conduction system pacing, his bundle pacing specifically. You can see it's basically narrow and below 120 milliseconds, which we consider normal. And you can see what happens if patients had bundle branch blocks. We were able to narrow it to 116 milliseconds, showing that we're actually recruiting the bundle branch at the site. They were ventricular paced. They had QRSs of 177 milliseconds. We reduced it to 125 milliseconds. And if they had narrow QRS complexes, we were able to maintain that without causing dyssynchrony. And overall, you can see a significant improvement in ejection fraction, significant improvement in functional class. So there's something about pacing that is bad, and there's something about conduction system pacing that is good. Intuitively, all of us would say, absolutely, that totally makes sense. But again, it's a hard thing to swallow for people when they're seeing it for the first time, saying, how is it even feasible to do something like this in patients with heart blocks? This is actually a study that several of us did. This was a randomized trial, actually headed out of University of Chicago, looking at, for the first time, patients who have indications in heart failure with BIV-CRT, the traditional BIV pacing, versus his CRT. It was a small trial. It's only about 40, 45 patients. This, again, no industry sponsorship. This was our own funding that we raised and did ourselves. And you can see here, again, it's not powered to detect at a statistically significant level, but every single aspect of pacing here favors conduction system pacing over biventricular pacing. Again, based on the physiology that I explained to you, totally makes sense that we would expect this to be better than current forms of pacing that are non-physiological. So based on this, and a lot of the data from ours, publications and all that, the guidelines have changed now to actually recommend and suggest that if you have AV block and your EF is mildly reduced, especially in this 36 to 50%, and you think you're going to be paced frequently, you can actually do conduction system pacing in lieu of cardiac resynchronization therapy. And in patients with de novo heart block with narrow QRSs, you can actually implant or try to implant conduction system pacing or his bundle pacing in this patient population. For us, this is earth-shattering because, to be honest with you, we don't have randomized trials. Usually, we don't make these kinds of recommendations without randomized trials. But the data, this kind of data that's out there is so appealing and makes sense intuitively that people feel strongly that this should be a form of pacing. I still think there needs to be randomized trials to really prove once and for all that this is the way pacing should be. There's another concept along this. So when we're talking about his bundle pacing, the original articles that I was showing you, we're talking about pacing along the, usually around the distal his bundle. But the his bundle then arborizes into a right bundle and a left bundle. So as a physician who were doing quite a lot of his bundle pacing, he stumbled upon this saying, you know, this is a narrow target to pace from. Why not go distal into the left bundle? That means usually our leads, the helix of the lead is hooked to just the superficial surface of the his bundle. Just like when you put an RV lead, if this is the myocardium, it just hooks to the myocardium. It doesn't go deep into the myocardium. So what if we can actually go deep into the septum, across the septum, and capture the fibers that are in the endocardium on the left side of the left bundle and capture directly the left bundle? Well, what about that? Because usually you'd expect remember the his bundle is surrounded by fibrous tissue, so thresholds can be higher, for example. What if you go into the tissue where thresholds are lower and we can directly recruit? Interesting concept. Initially, again, people weren't too sure. When he was doing it, he told us, initially we didn't believe it. Ironically, when nobody believed his bundle pacing, and now he's doing this and we're not believing it. But this is an example of it. So this is actually contrast on the right ventricular septal side. You can see this lead is actually going across the septum. So it's piercing the septum. So if you look at it on a CT, this is your RV, this is the interventricular septum, this is the LV cavity, LV endocardium. That lead is piercing across the septum and almost going to the LV endocardial side. A couple more turns, it pops into the LV, and it's floating in the LV. So that's how deep these leads are. So it's about a centimeter deep into the septum. Can we do this? And here's an example of this. So here's a patient with left bundle branch-induced cardiomyopathy, or actually, in this case, retrospectively you find out. So a lot of cardiomyopathies that we think, patient has heart failure and they have a left bundle branch block, they'll benefit from CRT. When we do this, they actually reverse, and they are what we call super responders, and they become normal. That tells you something that the left bundle branch was what probably causing cardiomyopathy. It's not the cardiomyopathy causing the left bundle. And there's a significant number of patients we're learning that are related to conduction system malfunction, in this case with left bundle, that when we corrected, they actually improved there, especially in the non-ischemic cardiomyopathy population. So this patient was referred for his bundle pacing. This is some intrinsic measurements that we do. So this is the delay. So the his Purkinje activation to ventricular activation usually is about 50, the maximum, or we consider normal, is about 55 milliseconds. This is twice that. So in the his Purkinje system world, this is like, you need to get a pacemaker. Even if you're not symptomatic, you don't have heart block, you don't have any demonstration of it, this is an indication for a pacemaker. And in this particular case, we tried that, the thresholds were high. So you can see this is going distal to that, into the septum, and this is the baseline left bundle branch block. This is with correction. So if you look at this ECG, if it wasn't for pacing spikes, you would not recognize that this is even pacing. And sometimes with bipolar pacing, where the thresholds are really low and we're pacing it, you can't even see the spikes and you can't even tell they're being paced. So again, here's a patient with a left bundle branch that we're completely correcting by doing this form of pacing. Now we're learning as time goes that potentially this form of pacing may be a little bit better than his bundle pacing, potentially because thresholds are better and we're directly stimulating the left bundle itself rather than stimulating the His bundle. Interestingly, if you think about left bundle branch block, we always think, if I go back to this picture, we have a little bit of time so I can explain this whole concept of when we're talking about left bundle branch block. So when you see on an EKG a left bundle branch block, our first impression is, oh, the left bundle is not working. And that's what we naturally all think until I started doing this. As an electrophysiologist, that's how I thought. But the way to look at the left bundle, that again, they showed this back in the 70s, are if I, from an AV node, and I want to run a bunch of cables to the right ventricle, a bunch of cables to the left ventricle. So I take all those cables and I wrap them up together and I run it from the AV node to the left bundle. I take all those cables, I run it from the AV node to the right bundle. Now I take all those cables, I wrap them up together, that becomes the common bundle. So when you have a left bundle branch block, it doesn't mean that you have left bundle branch block distally. It can occur anywhere from the His bundle all the way across the fibers to the left bundle. What we're also learning, that's why His bundle works, is a lot of these blocks are within the proximal or the distal portions of the His Purkinje system because they're predestined fibers that are going from there into the left bundle, predestined fibers that are going to the right bundle. So again, this whole concept of thinking of right bundle branch block, left bundle branch block being distally is just a false concept. Those can occur anywhere from the His Purkinje system very proximally, or in this case the distal His, all the way across the fibers. And of course, technology is evolving, industry is evolving. We're getting into more and more fancy types of pacing. Here's a pretty advanced LV endocardial pacing. So BiV pacing doesn't work well sometimes in patients. For example, the BiV pacing is dependent on where the coronary sinus or the coronary vein tributaries run. They don't run the same way in everybody, so you have to take whatever that's there anatomically and place the lead there. So you don't usually always get, ideally, you want to place the lead on the posterolateral aspect and the basal aspect of it because that's the last part to be activated when you have a left bundle branch block. But sometimes you can't find branches, sometimes you get what's called phrenic nerve stimulation because the left phrenic nerve runs right there, so you have to place it somewhere else. It's not ideal. So what if you could place it, do something endocardially? So this is a system called the Y system, YCRT. Essentially, this is, personally, I think this is crazy that we're going to this magnitude to do BiV pacing when we have conduction system pacing, but you have a biventricular pacemaker with just an RV and right atrial lead, and then there's a little pellet. It's basically literally the size of a pellet that's actually implanted in the LV endocardium, and then you have a little battery-supported transmitter that actually, based on when you get an RV impulse to pace, it will sense that and send a burst to activate this to stimulate the LV endocardium to get LV endocardial pacing. And obviously, this has to endothelialize over time because it's sitting in the LV, it can form clots and so on. So this is another form of pacing, but you can see the difference between something like conduction system pacing where you just do a regular pacemaker and something like this. What do you think industry is going to support? This is going to cost probably 5 times the cost of a regular pacemaker or 6 times the cost of a pacemaker, for example. So there's always competing interests when you're looking at what we think physiologically makes sense that's cheaper and economical versus something that's, looks sexy and costs a lot more, and it's great for, cool x-rays to show and all that stuff. So there's a lot of competing stuff, but it's changed quite a bit, though. I think physicians have driven our field so far that all the companies now are taking interest in conduction system pacing and spending putting more resources into it. Of course, there's the leadless pacemakers. So the ideal form of pacing for us, if we could design, would be a leadless pacemaker that we can implant in the His Purkinje system. There's no wires, there's no cables, there's no hardware that's floating around in your vasculature and so on and so forth. This is your traditional leadless pacemaker, the micro pacemaker that you guys hear all the time and see in your patients. Essentially, this is all self-contained capsule. Has some these prongs essentially that hook to the heart muscle and fibrose over time, and you're directly stimulating. But again, this is a good aspect of pacing because there's no wires and all that, but again, it's doing RV endocardial pacing, just like apical pacing. So still can cause pacing-induced cardiomyopathy. So we're not addressing that. All we're doing is miniaturizing a device, which I think is superior to a traditional pacemaker with all wires, but it's still doing the same physiologically like a regular pacemaker. So it can still cause RV pacing-induced cardiomyopathy. This was out on, I don't know if you guys saw it in the news in the last week or so. This, I believe, George Washington and I can't remember another university, Northwestern, I believe, combined, they developed a totally bio-absorbable pacemaker. So this is usually epicardially placed, so post-surgery, instead of putting epicardial wires, if they're dependent, they go into heart block, you can actually place this. And over time, it actually gets self-absorbed. It's only meant for temporary for a certain period of time. And you can see in the future where biological pacemakers are probably going to be a reality probably in the next 10, 20 years or so. People are developing these. So imagine somebody comes in with a complete heart block, it actually inject probably biological cells, whatever you want to, engineered cells and so on, that can spontaneously fire and actually excite tissue. So I think our field is going to change in the next 20 years significantly with these kinds of technological breakthroughs. I think I can save some time here. So in summary, pacing strategies continue to evolve. As you can see, in the last 100 years, from the time where we couldn't even pace people to a point where we have bio-absorbable pacemakers. And there's, again, with this, there's a global movement towards physiological pacing. I think you'll see more and more in clinical practice in the next 5 to 10 years or so. And different types of pacing, such as his bundle pacing and direct left bottom branch pacing. And also, finally, newer leadless technologies like we talked about, I think are going to really change the landscape of pacing as time goes. And again, a little bit about this, don't diss the hiss. So if you go on Twitter and do a hashtag search on it, you'll see probably, I don't know how many people worldwide have posted their cases. It's actually a nice repository to discuss. Since we started doing this, I get Twitter messages, private messages about asking about patients and how to manage and how to program and so on and so forth. So social media has become a huge part of what we do, especially in our field in EP. I can tell you it's not uncommon. Somebody is about to start a case and they'll send a mass through Twitter, send a message saying, hey, I'm about to start this case and I see these PVCs. Where do you think this is coming from? How should I plan? And you'll see about 20, 25 people. And these are world's experts. We're not talking about some guy sitting in some lab. These are people, who's who kind of people, immediately responding back saying, hey, this is what I would do. I would try to map this area, that area. That's incredibly constructive, at least if you use it the right way, in terms of having access to something that you never had before, in terms of doing round talks and so on. We have access to anybody anywhere in the country and the world, as a matter of fact, with expertise, who can weigh in immediately and say, hey, you should do this, you should try this, and so on and so forth. All right, I will end with that.
Great, thank you very much. Murray, do you have any questions yet? Okay, so then I get to start. This is the advantage of being the moderator. So how hard is it, Gopi? I mean, is this something that is going to require a center of excellence? What's the difference between doing the His bundle pacing versus your usual procedures you used to do for pacing? Right. Is it harder? Do we need to have 1 million people like you to go across the world to do these, or everybody do them?
Great question. In this day and age where we always about reducing costs, time, and being fast and so on, it has to be a little bit more meticulous because you are doing very site-specific pacing. It does take time. It does take some experience to do these. But the learning curve for people who do this regularly, if you implant pacemakers and biventricular pacemakers and all that, you're probably talking about 20, 25 cases. So yes, it may add a little bit extra time to the procedure, but this is something we're doing for a patient for a lifetime. So if it means you're spending another extra 20 minutes, 30 minutes on a case to get a result, that's going to last a lifetime for a patient. I think it's just a different mindset. You're right, but most people adapt it very quickly. Once they see the benefits of it across the world. Early on, we were going around training a lot of people around the world, actually, a colleague, myself, a few of us. Now, essentially, it's become pretty popular, and most people Twitter helps. They pick up how to do it on Twitter, and they go and they try it actually. And for the most part, it works pretty good. But it is a meticulous procedure. It takes a little bit more time.
So in this area, if you go to any of the major hospitals, they'll have this capability?
No. Unfortunately, it takes time. Some of them have actually, interestingly from this area, have come when I was at Indiana University. I used to have a monthly course. I've come there and learned, but not as much. They're slowly, again, picking it up. I think part of the problem was they wanted to come to Tacoma Franciscan to learn. When I first came here, everybody was excited. They were setting it all up, with even fellows and all that, but because of COVID, we couldn't do any of these. But ultimately, so I get referrals for these specifically for this type of pacing. But ultimately, yes, I think probably, I would say 20-30% of the EPs in this community can do this and will do this because that's the future of pacing. So ultimately, everybody has to adapt their practice to this.
Mary?
And I've had patients specifically worldwide come for this, calling and saying, can you do this? I read about this. This is what my physician suggested. Physicians themselves who need pacemakers have specifically sought this to get myself, colleagues everywhere, because people see the benefit of this compared to your traditional pacing.
So I said I was excited about this because I didn't know a lot about it. I've had a couple of patients recently get the micropacers and thought that was the new thing going forward. Right. And obviously that may not be. And in fact, that kind of gets me to the next question. If we had a medical condition that a certain percentage of people were going to develop cardiomyopathy because of it, we would try and intervene. So the question is, there's a lot of people running around with right ventricular pacing. Should they be converted to His bundle pacing, or let me change that. If they're pacing more than 20%, I saw your slide said, but 40% maybe in the literature. If they're ventricularly paced more than 40% of the time, should we be considering switching them to His bundle pacing?
Yeah. So there are two aspects to this. People who have traditional right ventricular pacing, if you look at, I remember at the beginning I was saying 99.5% of people worldwide still get it. And 80% of those patients do just fine. So there's something about that 20% of patients, 15-20% of patients, that certain type of pacing, a certain type of arrhythmia, or left bundle branch block can cause a cardiomyopathy. So we don't know which one it is. So when you're talking about 1 in 5 patients potentially, or 1 in 6 patients can develop this, you don't necessarily have to do anything except observe them. So what we tend to do in our clinics are that if we identify patients who are frequently paced, we periodically repeat their echocardiograms to see what's their LV function. And now we're recognizing more and more kids with congenital heart block who get pacemakers. Over time, their left ventricle start dilating. That's a form of cardiomyopathy they're starting to develop. So in patients who have traditional pacemakers who are doing just fine, again, vast majority of patients are going to do just fine. Just following them carefully for heart failure symptoms and reduced ejection fractions is the way to go. The advantage of this is if you're doing a de novo procedure, why take that chance of 1 in 6 patients developing pacing-induced cardiomyopathy when you have the chance? Why not just do the right thing in the first place instead of hoping and praying that they won't be 1 in 6 patients and I have to follow them with echocardiograms? So I think that's coming next, that shift in thinking. Right now, I don't think there's any need to rush and upgrade any of the patients. Majority of them do just fine. Yeah.
Yes.
Gopi, thank you very much for a fascinating talk. I have 2 questions for you. First one is, obviously this is much more nuanced approach and much more targeted approach to pacing. So can you elaborate on how you guys map the His bundle or the left bundle to see where the defect is?
Right.
And second question is maybe beyond the scope of this talk, but I'm fascinated by social media healthcare delivery. Can you elaborate? And I see the advantages of it and really the kind of immediate and real-time expert input, but I also see some issues with HIPAA and medical legal issues. Can you elaborate on the kind of the conflict on those 2 aspects of it?
Absolutely. So the first part of it is, this is actually, we don't do any extra mapping. It's just through the pacing lead. So with the pacing lead, we can actually map the entire His-Purkinje system from the proximal end where the block is. And so we're not doing anything additional. We're not adding any additional equipment to the procedure. It just takes a little bit more time because before you just put a lead in the right ventricle wherever you can and just screw it in and you're done and you walk out of there. Here you have to be very meticulous, map the region and know exactly where the site of block is and where you're going to be pacing from and see different types of responses and so on. So that's what, in a busy lab, a lot of people struggle, especially in practice, where before they could do, I could do 3 pacemakers in 3 hours and I'm done, I move on. Now 1 pacemaker may take you, or you may not do more than 2 pacemakers, for example, in that time. So I think that's where the struggle is, but again, the logic when people tell me that, I say, if that's you, this is a once-in-a-lifetime device you're going to get. Do you want the right one, spending another extra 20 minutes, or do you want to just say, because of time constraints, I'll take my chances? The second part of it is something that we all struggle with, all of us, on social media. Usually we talk to patients before we post, saying, hey, this is a learning experience for a lot of people who don't know how to do this, and this is a great example of this. Are you okay with it? They're all de-identified, so there's nothing there to identify the patient, except that if you are overzealous, and of course some of us argue that if you say, I'm about to start this procedure today, that's obviously identifying potentially a patient who's going to go through a procedure in your lab on that particular day, and somebody else may say, I think I know who this patient is. It's interesting, we brought this up even with organizations and how to handle it. There's no consensus on any of that. So organizations that are pretty good about it say, no, that's okay, as long as you don't put identified information on it. There's no way to track the patient, we're okay with it. Some will say, absolutely not, you can't do it, that's just a policy of ours. For the most part, vast majority of systems have accepted that as a learning tool, because it's more of how you use it. There are people who will post saying, hey, I'm the first in the world to do this, and those kinds of stuff. Most of this that we do is usually purely educational. And the downside of all those, and if you weigh the upside of it, there's no comparison still. Today I can probably go search you on Google and find everything about you. I don't need Twitter to tell me that. For most of us, all of our information is on not social media, but any searches we can find them. If I pay a company, there's plenty of companies, you pay $50, they'll give you the whole background of you or me or everything else. So it's a conflict, but for the most part, I think the educational aspect of it outweighs it, and it's also dependent on how you use it. People abuse it, people use it for the right reasons. So. But it is coming. I've had people on LinkedIn contact me, patients for the first time, saying, hey, I know you do this kind of pacing, or I know you do this kind of ablation, can I come see you? Out of LinkedIn. I have a handful of patients like that. I've had a handful of patients on Twitter send me a private message saying, hey, my family member so-and-so has this problem, has this, they want to do a biventricular pacing, what do you think? Can we come see you? So that's just the reality of where we're going with social media. So either we can embrace it and use it the right way, or we can just say we're not going to use it and probably be the last to be in that game, in that space.
We've got another question, but I want to preface this before she asks the question. This is the power of this type of being in an academic system. So this is going to be a gynecologic oncologist asking a question of our electrophysiologist. And I think that's great. So Dr. Amy Brockmeyer has a question for you.
Sheesh. I'm interested and curious to hear your comments about, you had mentioned multiple times or hinted at the conflict between industry and what you're doing, and that potentially your way is cheaper, lasts longer, only needs to be done once, et cetera, versus these other things which are disposable, have to be re-injected every 90 days or whatever. Can you comment on how you deal with that, or how you're dealing with industry, or how you address that going forward?
So I can give you a little bit of background story. We have a few more minutes. So this was something that when I finished fellowship and I joined my colleague who was very passionate about this, was just dabbling in that. So we both sat down, decided one day that this makes no sense. Why are we not doing this? This physiologically makes complete sense. Let's start doing it. So we both started doing it. It also goes with the institution where you are. They were very supportive. They could have simply said, no, this is crazy. This is something new. We don't want you to do this, and so on. So we did it prospectively, and we started accumulating a lot of data and outcomes, and started publishing these, and even manuscripts wouldn't accept it, saying, this is crazy. This doesn't make any sense. Is it safe? Blah, blah, blah. People didn't understand all that. So there's, at that time, and even now, there's really one company that's really has the lead. The lead was not designed for this. The lead was designed for a pediatric population to do regular pacing. But we basically jerry-rigged the system to try to make it work, and it works great. And as it was growing and the presence was growing on Twitter and so on, we started going to the company saying, you're sitting on a gold mine. This totally makes sense physiologically. It's going to, third world countries, for example, will tremendously benefit. A Bivi pacemaker is 3 times the cost for them. This is just a regular pacemaker. There's always a conflict of interest. You know, they're developing leadless pacemakers, and they have the next 5 years journey totally decided already, and they're on that course. What we learned was you can influence them in different ways. You can go there. We used to go every year to the corporate headquarters, sit there with the decision makers and say, what are you doing? Do this. Yeah, even make a joke. One day to all of them, I looked at them and we were so frustrated after year after year after year. I said, what's wrong with this picture? You have 2 guys who don't have any time in the world coming here and selling you your own product. Well, what's wrong with this picture? They had no answers. All they could say is we have to look at the bigger picture, or what it is and what we need to do and so forth. But what drove all this is actually, and that's what the paper we published on, is social media. Once we started going to social media, started placing these on social media examples, then somebody like in India would pick it up saying, hey, this is a great idea. I don't have access to biventricular pacemakers that cost an arm and a leg. Let me start doing this. And China and Southeast Asia, everybody started picking this up. Next thing you know, this became a revolution in China. China now does the most amount of his bundle pacing, our conduction system pacing, and they've become the place to go to train a lot of people. Yeah, I mean, just totally taken off there, and they're doing studies and everything else. They can scale that much faster than we can. They can get research studies going a whole lot faster than we can, and so on. So social media and interests like this, with physicians driving it, has now changed all the companies. Now all the device companies all have a platform and what they want to do with conduction system pacing, including the one company that had all that stuff. So they're all developing it, but they would have never developed it if it wasn't for physicians actually driving this, saying we're going to do it whether you do it or not, and so on. So that's why it's a great example of we may think we don't have the power anymore. Industry decides, or pardon my language, everybody's going to be hearing here, but administration decides. It's not true. Physicians still have a significant voice because we're the ones that take care of patients and we can drive change. And that's what I've become a believer that we can do that. But it's a lot of effort. This is not an easy thing to do. It's exhausted us trying to do this for a long time.
So we're okay. So I have another question related to, for guidelines. If I have patients with standard pacers, should I be doing a echocardiogram once a year, once every 2 years, to see if they're going from 45 to 30 ejection fraction? And at that point, that's when I would ask you guys, I'm losing ejection fraction here in this patient that's ventricularly paced. Right. Should we be considering his bundle pacing?
Yeah. Great question. These are all answers we don't have right now. So we're actually writing our society guidelines right now, specifically. And we were just having the discussion of what is the right amount. And you can put 10 people, 10 experts there. They have 25 opinions. So nobody knows what is the right thing. So it depends on your practice. So I personally tend to do echocardiograms in these patients once every 12 to 18 months or so if they're predominantly paced. If they have any signs or symptoms suggestive of heart failure, anything at all, exercise tolerance goes down, anything, then immediately we repeat it. But if it's not that and you're just following a totally asymptomatic patient, usually probably about every 18 months or so is what we follow. I can tell you vast majority of patients don't get follow-up ultrasounds who are pacer dependent. We only do them if they have symptoms.
If we lowered the cost of an echo and just set somebody for an echo simply for an ejection fraction estimate, would that be less expensive? And would that be
you
easier?
can do a limited echo specifically looking for EF assessment, and that is cheaper. The funny thing I'll say is just like Apple Watches and all that, it's a matter of time where diagnostic stuff are going to be accessible to everybody. You can buy an echo machine, a portable echo. Right. Anybody, as a consumer, you can just go buy an echo. It's not restricted to anybody in the medical field. And you can do your own echoes if you want.
Right, and so primary care is getting mobile ultrasound
Right.
or in-office ultrasound.
Right.
How technically hard is it? Is it going to be pretty reliable?
It's not so much of doing it, it's in the experience of interpreting it. I mean, you have to have good acoustic windows, good images, and have the expertise of interpreting it. So that's where the challenge with these come is how good are you in doing these? Because if you think about a cardiologist doing this, you do this all your life, you're trained, and every day you're looking at tens and tens of echoes. So that's where the challenge will be, is when you're starting to adapt it to people who are not experienced. Just going to a weekend course and coming back doesn't give you the same expertise. So at least it may tell you something. Where I think it's good is as a screening tool in primary care. You do something at the patient bedside in clinic and you say, you know what, this looks abnormal. Let me get a formal echo to follow up on it. If it looks normal, I don't have to do anything. You can always tell the normals and the really abnormals. It's the in-between is where you struggle if you're not an expert at it.
I think that's it. This has been outstanding.
Oh, thank you.
We'll bring you back maybe in the fall to talk about social media for Dr. Hupka, if you'll be amenable to that. And thanks everybody for attending.
Thank you.